You've had blood drawn, watched a number print on a page, and been handed a verdict on your heart risk based on a formula the 2026 guidelines just retired. I'm Elliot Hayes. Welcome to MedHeads. For 8 years, cardiovascular risk in the US was calculated using something called the pooled cohort equations. Your age, your sex, your blood pressure, your LDL cholesterol, all fed into a formula that estimated your 10-year risk of a heart attack or stroke. The problem? For many people, those equations were overestimating that risk by 40 to 50%, according to the ACC and AHA's own review. Not by a little, potentially by half. That's a formula that steered millions of medication conversations for almost a decade. So the 2026 guidelines replaced it. It wasn't a refinement, it was a retirement. What replaced it asks a fundamentally different question, and that question changes everything about how risk is calculated for people in their 30s. The new tool is called the Prevent ASCVD equations, short for Predicting Risk of Cardiovascular Disease Events, built for adults aged 30 to 79 without existing heart disease. What's different? It gives you both a 10-year and a 30-year risk estimate. For a 35-year-old with mildly elevated cholesterol, the 10-year risk often looks reassuring. Almost everyone's does at that age. But 30 years of that same cholesterol level accumulating in the arteries tells a different story. The old tool was a 10-year snapshot. Prevent is more like a slow pan across a lifetime. It's not that short-term risk changed. The question just got longer. But even the best risk calculator is only as useful as what it's actually measuring. And the standard cholesterol test, it turns out, is missing something. The number you've always seen on your blood test, LDL-C, measures the amount of cholesterol packed inside the particles circulating in your blood. What it doesn't count is the particles themselves. ApoB, apolipoprotein B, is a protein that wraps around every single atherogenic particle in your bloodstream. 1 molecule per particle without exception. So measuring ApoB means counting the vehicles, not weighing the cargo they're carrying. Two people can have identical LDL-C readings, the same cholesterol number, while one of them has twice the particle count. Twice as many chances for a particle to burrow into an artery wall. The 2026 guidelines now formally recommend ApoB testing for people with diabetes, elevated triglycerides, or established cardiovascular disease, the groups most likely to look fine on a standard panel, while something is quietly happening underneath. LDL-C wasn't measuring wrong. It just wasn't measuring the particles. Which brings us to the headline that stopped a lot of people short. Statins from age 30. Here's what the guideline actually says, because the headlines compress this. It doesn't say every 30-year-old should start a statin. It says, if you're under 40 with an LDL-C of 160 milligrams per deciliter or higher, or a strong family history of early heart disease, or a high 30-year risk on the Prevent calculator, that's now a conversation worth having. For a typical healthy 35-year-old with normal cholesterol and no family history, the change is more modest than that. It's, let's calculate your 30-year trajectory now, rather than waiting until you're 55, and the question suddenly feels urgent. Low-dose statin therapy started early and held long-term carries a very different risk-benefit picture than aggressive treatment started late. And the evidence behind LDL-lowering therapies is genuinely strong. This isn't a new drug searching for patients. It's a well-understood intervention being reconsidered for a longer window. The threshold for treatment didn't lower. The starting point for the conversation did. These guidelines don't prescribe an answer. They hand you better questions to take into your next appointment. Have you had your cholesterol checked recently? And did your doctor talk about your 30-year risk or just your LDL number? Comment below. I'd genuinely like to know what conversations people are actually having at their appointments. And if this kind of evidence-first explainer is useful to you, subscribe. There's more coming.